We'll hear next from David Raleigh about radiation modalities. That's our penultimate talk. So 2 more to go, totally. David is a principal investigator and director of the preclinical therapeutics core at the BTC. David?
It's my pleasure today to talk about radiation modalities and strategies for extra-axial tumors. I have no disclosures. So towards the caboose end of today's symposium, I've been tasked with talking about radiotherapy for more than 50% of all the primary intracranial tumors that are diagnosed in the United States. And perhaps a more inclusive or specific, I should say, title for this talk could be radiation modalities and strategies for meningiomas, pituitary adenomas, and schwannomas. Now, coming on the heels of a nice pituitary adenoma surgical presentation, I thought it would be nice to start with radiation modalities and strategies for pituitary adenomas. Broadly, radiation should only be considered for these tumors when medical and surgical options have been exhausted. And conventionally fractionated approaches such as IMRT or protons are used for tumors with less than a couple millimeters of separation from the optic apparatus, or large tumors, as shown on the left of this slide. And in contrast, gamma knife or LINAC-based SRS is much preferred for small residual or recurrent tumor deposits with a couple of millimeters at least of separation from the optics, as are shown on the right. These are very much preferred for patient convenience and for the potential opportunity to spare the infundibulum or normal residual pituitary gland from excess radiation dose. This paradigm very much supports a role for operative tumor debulking prior to radiotherapy to reduce the radiation field size. Now, that being said, I regret to inform you that there is very little that is new or is changing in terms of radiotherapy modalities or strategies for pituitary adenomas. There's been a number of review articles focusing on radiotherapy and the management of pituitary adenomas with emphasis on contemporary studies over the last 5 years or with extensive follow-up. This is one of my favorite from Jay Loeffler and Helen Shih from the Harvard group. And in sum, what these studies demonstrate is that we have a 90 to 100% success rate in controlling tumor growth, regardless of the radiotherapy technique or the adenoma subtype. Hormone normalization, however, is more variable, with differences in patient technique and doses and definitions of success across the literature. But in general, we typically anticipate or quote a 50% success at 10 years after treatment. Regardless, if we are treating large field, hypopituitarism is an expected side effect of this treatment. But the overall rate of other treatment-related adverse effects is very low. Now, in contrast to pituitary adenomas, the vast majority of vestibular schwannomas can be effectively and safely treated using single-session stereotactic radiosurgery, typically to a marginal dose of about 12.5 gray in 1 fraction. These data are from 162 consecutive patients with vestibular schwannomas who were treated with single-session gamma knife SRS at the University of Pittsburgh and were reported in the New England Journal of Medicine way back in 1998. Demonstrating excellent rates of long-term local control, with the majority of tumors shrinking or remaining the same size on long-term follow-up, and a very favorable side effect profile. Of course, these data have borne out in much larger series since that time, including these tables on the far right of this slide, from a follow-up publication from the University of Pittsburgh, reporting outcomes of 892 patients with vestibular schwannoma who were treated with SRS, resulting in a gaudy rate of long-term local control of 98.6% in the setting excellent hearing preservation. But as Dr. Theodosopoulos astutely noted, as he is so inclined to do, we know that these data don't really tell the whole story about the natural history of vestibular schwannomas that are treated with SRS. Indeed, approximately 2/3 of vestibular schwannomas that receive gamma knife experience transient and largely self-limited oscillations in tumor size over the course of many decades of MRI follow-up. These images are from an excellent editorial from Jean Regis, published a few years ago, showing 2 cases of relatively small vestibular schwannomas that were treated with SRS on the far left, and later increased in size dramatically, only to regress spontaneously on long-term follow-up. Now, at UCSF, Dr. Theodosopoulos has quantified these changes over time, showing that not only are transient oscillations in schwannoma size really common after SRS, but they became increasingly more likely over time. These volumetric magnetic resonance imaging data are from 118 patients with vestibular schwannomas who were treated with gamma knife SRS at UCSF. And as you can see, not only are these changes present in about 2/3 of patients a mere 6 years after treatment, but they become more and more likely over time. So the question then becomes, what can we do about schwannomas demonstrating these changes? Well, steroids seem to do a good job at reversing these symptoms from these oscillations, and salvage surgery can be considered for refractory or recalcitrant cases. And now large schwannomas that aren't amenable to either SRS or surgery can be treated with either fractionated or hypofractionated radiotherapy. The data in these Kaplan-Meier curves come from a pooled meta-analysis of vestibular schwannoma outcomes from 3 German centers comprised of 449 patients, about half of which were treated with gamma knife SRS, and about half of which were treated with fractionated or hypofractionated radiotherapy. And as you can see from these hard to discriminate Kaplan-Meier curves that are kind of there in the middle of the slide, there really aren't any differences in long-term local control with either SRS or fractionated radiotherapy of these tumors. Obviously, the fewer fractions you can get away with, the greater logistic benefit it is for the patient. And so we much prefer to do single session treatment when we can at UCSF. And that being said, for larger schwannomas, we've adopted a strategy whereby we use 25 gray and 5 fractions with a stereotactic head mask and an image-guided setup. Now, we might use more conventional approaches such as 54 gray and daily 1.8 gray fractions for really large schwannomas that are intimately associated with critical neurologic structures like the optics or the brainstem. But given how good SBRT approaches have gotten over the last decade, this is really rare for us. And typically we are doing 5-fraction SBRT techniques. And we also use the same dose and fractionation for spinal cord schwannomas, and even those that are more peripheral, 5-fraction SBRT. Now, for meningiomas, the data supporting single session SRS is basically just as robust as it is for schwannomas. Likely the best data in support of this paradigm were published from 4,565 consecutive patients with a gaudy 5,300 imaging-defined or WHO grade 1 meningiomas that were treated with gamma knife SRS at 15 European centers, showing 5- and 10-year progression-free survival rates of 95% and 89%, respectively. Now, here at UCSF, we published our experience with single-session SRS for meningiomas a couple years ago, and up through 2007, this cohort was comprised of 280 patients with 438 meningiomas of all grades. As is the case for conventionally fractured radiotherapy for meningiomas, we find that outcomes are pretty good for imaging-defined and low-grade meningiomas on long-term local control, but outcomes are not as good with SRS for either high-grade meningiomas or those that were too large or had received prior radiotherapy. So how do we choose what type of radiotherapy to use for meningioma patients? Well, as shown here on the right, small meningiomas with at least a few millimeters of separation from the optics are typically treated with single session or 5-session SRS. And in contrast, as shown on the left, large meningiomas, or those that are intimately associated with critical neurologic structures, are treated with conventionally fractionated intensity modulated radiotherapy more often than not. Now, although we know from numerous single institution retrospective studies spanning many decades and demonstrating radiotherapy provides very good local control for meningiomas, amazingly, we are just now getting around to running prospective trials to validate the utility of this approach for meningioma patients. In that regard, RTOG 0539 is the very first trial to report any results. And so it was a phase 2 study of observation for low-risk meningiomas and risk-adapted radiotherapy for intermediate and high-risk meningiomas. Those risk strata are spelled out on this slide, and I think they've been adopted pretty well into the radiation oncology kind of lexicon. I'm seeing them a bit more in some of the surgical literature too. And I think these risk groups do a nice job of encapsulating a lot of the biologic diversity that we see across different types of meningiomas. Now, RTOG is now closed. It's accrued 244 patients. The early results from this trial, which was, of course, the first successful cooperative group trial for meningioma, are encouraging and consistent with retrospective data, suggesting 3-year progression-free survival exceeding 90% for low and intermediate risk meningiomas, and as is the case for SRS approaches, and really any approach you like for high-risk meningiomas and grade 3 tumors in particular, the results are less good. Again, these data are consistent with retrospective data, and the side effect profile of these treatments appear very tolerable in patients who were treated on RTOG 0539, which was supported by a similar phase 2 study that was published from Europe, namely EORTC 22042. But significant questions remain regarding radiotherapy from meningioma patients. In particular, whether or not in a randomized setting we can demonstrate an unequivocal benefit of radiotherapy for meningiomas. And there are two presently open multi-institution randomized studies that are trying to answer that very question, specifically for grade 2 meningiomas that are treated with gross total resection, either NRG BN003 or the Rome study, otherwise known as URTC 1308, take such patients and randomize them either to close surveillance or adjuvant radiotherapy. That randomization between doing nothing and literally doing 6 weeks of adjuvant radiotherapy, I think, should illustrate how much confusion there is in the field about which meningioma patients should and maybe shouldn't get radiotherapy. With changes in radiation technology over time, the hypofractionated regimens I mentioned, with brachytherapy being used for meningioma patients, as Dr. Braunstein noted, we often use for our brain metastasis patients at UCSF. It presents additional options and opportunities for us to treat patients with some of these more recalcitrant, problematic meningiomas. And last, but certainly not least, an integration of meningioma radiotherapy paradigms with meningioma biology or magnetic resonance imaging features, I think will very much be a part of how we think about and treat meningiomas going forward in the future, as we try to further individualize and customize our therapies for a very heterogeneous group of patients. So on that note, I will stop my presentation. Thank you very much for your time.